Good morning, everyone. Good morning. Thank y'all for coming. We appreciate y'all coming this morning. We're going to start our wellness series, our wellness arthritis series with Dr. Jeffrey Wilson this morning. So this is the first series of the series, Diagnosing Arthritis, Aches, and Pains. So I just want to mention that when we go to ask questions at the end, I will come around with the microphone so that we can hear the question as well. And I thank y'all for coming. So I want to introduce, as if you don't already know him, Dr. Jeffrey Wilson. So let's give him a warm Westminster Canterbury welcome.
Thank you, Denise. Everyone here in the back adequately? Good. When Denise asked about this series, I thought, well, you know, arthritis, who's going to have that? And the answer is everyone over 21 years of age has some wear and tear arthritis, so we all do, kind of in that together. Any country music fans here? Okay. Dirk Bentley had a song, What Was I Thinking? As we go through this, what I want to have you think about is I tell you, we have different things that come up. What was rheumatologist thinking? What did it mean to me? What were we considering? As we go through, if you find something you say, gee, this relates to me, then make a little check mark. And we're going to have you figure out where you fit in this scheme of things in terms of inflammatory arthritis, wear and tear arthritis, metabolic diseases, systemic illnesses, infectious, infectoid, fibromyalgia type problems. And it may be a mixture of things, but you'll be doing the work. I'm just going to explain what I was doing. Most of the time, before we even saw the patient, we had a sheet of information. As you all know, the sheets we all fill out as we come in. And in there, the patient profile started off, first of all, the age of the patient. And the age, we knew that in the 40s, patients usually present maybe at that time with rheumatoid arthritis and some of the connective tissue diseases. And if the patient is under 40 or under 50, we think less in terms of polymyalgia rheumatica and diseases like that. If they're over 50, then we start thinking about polymyalgia rheumatica, things that are age-related. So the age tells us one thing. Sex of the patient, well, certainly connective tissue diseases. If it's a female, we're thinking more along the more likely to have connective tissue diseases. The race of the patient, it's interesting. The black patients usually and younger patients have more, make us think more connective tissue diseases, more suspicious of that. Males perhaps have more in terms of polymyalgia rheumatica, temporal arteritis, these diseases that the rheumatologist thinks about. The marital status. A lot of times if I had, say, a 42-year-old white married female or separated female, and she's got two teenagers at home, I'm starting to think this patient may be a setup for things, extra problems like stress and fibromyalgia at home. These are things the rheumatologist thinks about. Where are they from? Well, gosh, this patient is from up around Amherst, and she's in a whole area that I had a whole bunch of patients who had tick-related diseases, so I'm more suspicious of tick-related diseases. That's how the rheumatologist starts to think on these things. I always like to have a list of medical problems, just a list. The patient's had hypertension, high cholesterol, maybe they've had some operations, and it tells me, as we consider things going on, of diagnosing how things may fit together, what medicines may or may not go along with their other medical problems. This is just a whole little sketch of the patient. What medicines are they on now? Need to know that. And we always need to know the over-the-counter medicines as well, because a lot of times people don't consider those as part of their medical profile, yet that may have to determine how medicines you'll use later with their arthritis. Are they taking physical therapy? Are they using a walker? What's the status with using braces, with a cyclid nail, all these things, and usually have that information before we see them. The next thing is the onset of the problem. Was it a sudden onset or something very gradual? One of the characteristics of polymyalgia rheumatica or temporal arteritis, patients will say, you know, I went to bed and I woke up the next morning, I was 100 years older. And about 2 weeks later, they'll come back and say, you know, you started me on that medicine, and the next morning I got up and I felt like I was 50 years younger. So nice. So the onset, that's really important. How did that start? And we want to know what sort of inciting agents, what things may have brought on this problem, this arthritis problem. Could you tell within 4 to 6 weeks before, was there a new medicine that you had? Did you have an infection? Did you have COVID? Gee whiz, we've seen some really amazing things and see long-term sequelae with COVID. So infections, did you have any sort of medicines you may have had a reaction to causing arthralgias and aches and pains? Any injuries or trauma? Did you have a vaccination? Did you have a response to vaccination that's caused arthralgias and myalgias, all kinds of rheumatologic symptoms? So these are the things that we want to be thinking about, as we're working through this with you. In the past, what medicines have you tried in the past? There's nothing worse than going through a patient's evaluation and say, we really got this great medicine for you. I want you to try X, brand X. Oh, I already tried that. We don't want to know ahead of time. Don't want to repeat that part of history. Did you have any injections? And we know that patients who had, say, a wear and tear arthritis in one joint and say, well, I had an injection of steroids, it didn't help. Or it did help for 6 months or so. Need to know that. Lovely way of finding out if you have an inflammatory problem going on in one joint, say you just have a knee that's bothering you, injected with steroids, did it help a lot or not? Because that really tells you how much anti-inflammatory medicine is going to help. So as you're coming down on this, sort of be thinking about those things if you were going to be writing this down to put in your chart. Morning stiffness, AM gel. Anyone wake up with any stiffness in the morning? Sure. And, I was talking to friends of ours, and we were saying how we used to be driving on trips, and we'd get down to a stop at one of the rest areas, and we kind of look over and say, gee, those poor old folks, look how slow it is getting them out of that car, getting out of that door. And now we look over and say, there's one of my friends, because I know exactly how they feel. But the morning stiffness we're particularly interested in for inflammation, inflammatory conditions. Someone has like several hours of morning stiffness, particularly stiffness, say, in the hands, that work out 2 or 3 hours later. If they're having less than 30 minutes of stiffness or 5 or 10 minutes, that's just part of us. That's just part of aging probably. But then we want to know about special inflammatory types of stiffness that's suggested by your history. We want to know what's happened with your joints. In other words, you say, gee, the stuff started, I woke up one morning, I was having pain, in both hands. And did it stay there? Did it go elsewhere? Did it go to the feet? Was it transient? Did it go there and then go away for a while? Or I woke up and I was just having a problem in my back, and that persisted. Did it have just problems in my knee, and that's consistent and gotten worse as time's gone on? Or did it all go away? Was it just a transient? All those things give us clues as to what kind of arthritis is going on or what elements are going on with your arthritis. Have you had any operations? And obviously that's important as well. So I hope you're all jotting down, because this is your history. And you want to see how that looks when at the end we say, how are you going to put all this together? Always interested in the family and social history. Any family history of general disorders in the family, diabetes, cancer, hypertension, heart disease. And when we get into a thing called the Rheumatologic Review of Systems, that will really relate to specific family histories that may tell about a type of arthritis that could be bothering you. It's not simply a matter of a little arthritis, but try to define exactly as best we can what's going on. Always interested in the social history as far as alcohol use, tobacco use, illicit drugs, and so on. In allergies now, we always worried about allergic reactions to drugs. We know different medicines we may want to try later on may cross-reactive medicines that we're trying with in your case. And also about seasonal allergies. And then, of course, now meat allergies and food allergies are really coming of more prominence with the alpha-gal. Any of those that have affected you. Then we get into the Rheumatologic Review of Systems. And if you look at the page there, it shows the general workout form that I have on my patients that I fill out. The first things that we look at really are things that would give us a clue to connective tissue diseases. So we start off with alopecia, hair loss. If you had diffuse hair loss, patchy hair loss, those all have different significance. Skin rash, almost any sort of a skin rash may give us clues to different types of arthritis. And if you do, is it red? Was it itchy? What was the distribution? Was it on the arms? Was it all over? Just one particular area? Had you seen the dermatologist? What did they think about it? Was it itchy or not? And then the question is there psoriasis in you or in the family? It ended up in probably the last few years that psoriatic arthritis was the second most common inflammatory arthritis that we saw. And I almost never had a patient sent to me who listed in their own the psoriasis as a medical problem. They wouldn't list it. And their doctor who referred them never referred them with the suspicion of psoriatic arthritis. So a lot of times we'd see the patient, we'd see the pattern of involvement of the joints, we'd say, gosh, do you have psoriasis? Well, yeah, does your doctor know about it? Hadn't noticed it. So all these things sort of give us clues, not only in you, but in the family. Some of these disorders will run in the families. Connective tissue diseases, one member may be having problems with skin rash, giving us a clue. Another may be having photosensitivity problems. Does it bother you when you're in the sun? Not that you just burn badly, but are you really getting sick in the sun? That's sun sensitivity, so typical for connective tissue type diseases. Anybody with Raynaud's phenomenon, know what that is? Cold exposure, get changes in the skin color, maybe white, blue to red. And we know the classics change, white, blue to red, is more typically seen in other connective tissue diseases, but a lot of times they have an atypical presentation. Some will just have a white change maybe to blue and not typical to white, blue, and red. I remember years ago having a young girl that was coming in for evaluation of the Raynaud's, and it came in, it was in the wintertime, and I came in at lunchtime and she was standing outside. And she was standing, so I would not think she was crazy, that she really was having this. And here she came in and scared me to death. I thought she was going to lose her fingertips. Completely white now, it looks like dead flesh. White, blue to red, Raynaud's. That's always a tip-off. You want to know about the ANA test, their tendency to connective tissue diseases in them and in the family. And I'm sure other people will have this, maybe of a non-atypical form. Serositis. And these, when we're going through this review of systems, it's not only you, but it's also like your family members, children, and so on, siblings. Serositis is any kind of inflammation in some of the joint or the linings of the body cavities. Did you, in the past, or anyone in your family, have pleurisy, hospitalized with pericarditis? All those give us clues, I think, that help figure out what's going on. And any kind of chest pain. Nasopharyngeal ulcers, sores in the nose or mouth. Anything you know that brings those on, you or anyone in the family. Anemia, low blood count, low white count, low platelets. I remember John Davis, who was a grand master of rheumatology at UVA, always said if someone is not having low blood counts, signs in the CBC picture, hematocrit, white count, platelets, they probably don't have active lupus. A good thing to have in mind, but maybe they had it in the past. Kidney problems. Have you had any trouble with any kidney trouble, any abnormal urinalysis? The doctor said, gosh, you've got red cells in the urine, you've got protein in the urine, there's something abnormal about this. Another tip-off that something's going on in the connective tissue line. Connective tissue diseases, we'll talk about maybe the third talk. Those are really a spectrum of diseases from rheumatoid arthritis at one end to lupus at the other. And in between are scleroderma, Sjogren's, polymyositis, dermatomyositis, these things that you may have heard of. All of these may have similar overlapping features. The involvement, the pattern of your arthritis involvement is really important as well. For instance, most of the time with small joint arthritis presenting with rheumatoid or any of these connective tissue diseases, they'll often present with involvement of the MCP joints and PIP joints, and those are the upper joints. Almost never involve the distal joints. So it kind of helps us to say, well, we had the involvement of these distal joints, and you see here the rheumatologist has some of that. And the distal joints, the DIP joints, never rheumatoid arthritis, maybe psoriatic arthritis, most commonly with osteoarthritis. A thing called sarcoid, systemic illness can cause changes there. Rheumatoid does not. A bizarre thing called multicentric reticular histiocytosis we think about, saw one time. Gout can occur in the distal joint, and a thing called pseudogout. Years ago when I was giving a talk and having some of the residents spending time in my practice, I always like seeing the family practice residents now. I give a talk because I have most of them do a rotation in rheumatology, and I always say, I know you always remember the 6 causes of DIP arthritis. Tell them to me. Sometimes they can, a lot of times they can't. But I remember some people have, one of our good family practice doctors, Kim, was doing a rotation with me. She came in the morning And it was, gosh, it must have been about 30 years ago. She was a young resident, I was a young doctor. She came in, she said, sex. And I said, well, Kim Combs. I said, I'm flattered, but I'm married. I've been married, 35 years. She said, no, stupid, 6. There are 6 causes, and she's the one that told me about pseudogout is another cause of the DIP joint arthritis. So you never know what you'll learn. You continue learning all the time. Symmetric small joint. Now you say, gosh, my involvement was, it was really started in a large joint, started in my knee, or started in an elbow, and then it went away, and then maybe to an ankle, and maybe it migrated around. Was not additive. Well, that maybe have you thinking more about not just osteoarthritis, but pseudogout, some of these metabolic diseases, and, as well as psoriatic arthritis. Your involvement is in your back. Well, rheumatoid arthritis doesn't affect the low back, but there are other types of arthritic disorders that do, called spondyloarthropathies. They tend to run in families. Tip-off is, one is, I may be awakened in the middle of the night with back pain, may be very stiff in the morning. It may radiate down one leg or the other. It may alternate one leg for a while, the other leg. Rarely goes below the knee. More tip-offs that we're going to be thinking about, these spondyloarthropathy disorders, HLA B27, things we'll talk about more in the future. Do they have easy bruising? Anybody have any dryness of the eyes or mouth? Okay. And Sjogren syndrome, we think about that again, in that family of connective tissue disorders. One of the things that we'll find out that relates to this is at the end of it, we say, gosh, I'm suspicious for this. What tests do we do? It tells us which tests we look at, all these autoantibodies. Autoimmune diseases are on an increase. Fascinating sort of observation that I think will be important to all of us as time goes by here. Have you had any nodules, lumps, bumps around these joints, particularly around the elbows? You may have swellings that can relate to rheumatoid arthritis, or it may be gouty deposits. You have gouty deposits on the feet. Again, a tip-off to different disorders. GI problems are really interesting now. Probably the most common GI abnormality in Lynchburg now. I was called and asked by a friend about who she should see about this. Bob Richards in gastroenterology is finding more people with alpha-gal disease causing gastrointestinal symptoms, diarrhea, belly pain, than any other thing right now in Lynchburg. And we get right back to the thing. I'm a real zealot about vitamin D and alpha-gal because it's most underdiagnosed disease in Central Virginia, I think, because it presents in many different ways. So, but the other GI symptoms are inflammatory bowel diseases, Crohn's disease, ulcerative colitis. As we're talking to the patient, we say, did you or anyone in the family have any trouble with inflammatory bowel disease? Because you'll see a mixture. You're going to say, well, gee, my first cousin has psoriasis. Another cousin had Crohn's disease. And they're all sort of interrelated, usually by the inherited genetic susceptibility that's shown by the HLA B27 test. We'll talk about genetic susceptibilities in the future, but one of the main ideas now is that we're all born with certain susceptibilities. And the question is, what triggers these? And if you think about it, these spondyloarthropathy conditions are very interesting. HLA B27 is an inherited histocompatibility antigen, and it's in about 4% to 7% of our country. But if you take a look at people with ankylosing spondylitis, Reese-Struppel's arthritis, they used to call it, some of the forms of psoriatic arthritis and inflammatory bowel arthritis, they may be present in 60 to 96%. So what a strong association. Something really makes these people more susceptible. And then the question is, what triggers it off? You're susceptible, what triggers it off? And we know that in one case, classic case, which Jim Hunter here was involved in years ago, a destroyer went out from Portsmouth, and the men all got salmonella, diarrhea disease. And as for most of them, it was a Shigella, dysentery, same thing. Like most of them, they would have diarrhea for 2 or 3 days, get over it. But there were about 9 or 10 of them that had an arthritis started, and it persisted. This was in the 1960s. This was before they knew anything about these HLA inherited B27 tendencies, genetic tendencies. So one of the good rheumatology classic articles in the 70s was these two guys, Kalin and Fries, went and checked up on these folks. Now they have the HLA-B27 test done, and they're saying these folks are so much more susceptible to this disease. Do these folks have it? Yes, they're the ones that their Shigella triggered off this rheumatologic disease. There was a good example of infection triggering off disease. Now we're seeing more and more triggers that may be causing arthritis problems, particularly in groups of people with inflammatory arthritis. Nobody writing down, nobody has any inflammatory arthritis in the family, none of these sort of things. The other thing that, as far as symptoms, we're really interested in, it's probably more of an urgent problem in people that are our age, is the problem when people say, gee, you know, I have a new headache. Headache I never had before. I've got pain in my, temple area, or pain to touch on the scalp. I have pain in my mouth when I chew my food. I have temporary loss of vision, one eye or the other. Well, bingo. We're really worried about inflammation that's going on in these vessels in the head, a thing called temporal arteritis or giant cell arteritis. It's a cousin of polymyalgia rheumatica, when the person was waking up sometimes with that morning stiffness for several hours. Distribution of joints more in the shoulders and the pelvic area. But that's a real emergency that I guess probably about once or twice a year I'm called by either an old patient or a friend or somebody in the church, and so-and-so's going on, and we ask that question. Pain in the mouth, chewing the food, temporary loss of vision, got to have a sed rate right away, and you need to be on steroids immediately to save from a stroke or blindness. And anyone had any family history that's had that? I said, this runs in families too. Anyone aware of that in any of their families? One of my patients who was a grand old patient that we wrote about in the book that came in, she came into the office. And I have a wonderful nurse, Jean Henry. Some of y'all experienced her. Some of my old patients back there. And she came out of the exam room. She checks the patients in, checking their blood pressure and pulse and so on. And came out, first time I'd seen her sort of excited. What's wrong? Miss so-and-so in there doesn't have a pulse or a blood pressure. That's usually a bad sign for your patients. And I actually had another patient that was similar like that who was admitted into the cardiac care unit over one lunchtime, having some chest pain. And I came back to the office. I said, they're going to call in a panic in about 45 minutes from a cardiac care unit. So sure enough, this guy had the same problem she did. The temporal arteritis caused pulseless disease. The thickening of the vessels and blood vessels, the inflammation, stopped the transmission of the pulse and the blood pressure. And these people, he was just sitting up there reading his paper, and the nurse came in, Dr. Wilson, no blood pressure, no pulse. What's he doing? Sitting there reading his newspaper. Don't worry about it. Well, just the same thing with this lady. But I went in there and I said, Dean, a wonderful lab tech, set up a sed rate. We've got to know if her sed rate's high. Patient over 50, sed rate over 50, you're really worried about temporal arteritis, giant cell arteritis. Then came back in about 30 minutes. Her dead sed rate already decreased to about 60, should be about 10, go down about 10 millimeters in an hour. So she was very hot, very inflamed. So I just said, well, stop everything. You've got to get started on prednisone. Take it now before you leave the office. I'm not taking prednisone. So what do you mean? Prednisone killed Aunt Sadie, or my Aunt Sadie. And I said, well, what do you mean? And she said, prednisone just makes you gain weight and all this other stuff. And Aunt Sadie had it as part of her chemotherapy. It didn't kill her. So she went home, and I said, you are really worrying me. You at any minute could have a stroke or blindness, and it may not be reversible. So she went home. Well, just then, Lynchburg is a wonderful place to practice medicine, because all these people are sort of associates, friends, and so on. It ends up that her bridge partner was the widow of one of our most prominent doctors. And she went home. She said to my friend's widow, she was concerned. She said, "What did Dr. Wilson tell you to do?" She said, told me to take prednisone. She said, "I'm not going to do it." She said, "Listen, you go back and do exactly what Dr. Wilson says." So nothing that I said made a difference, but her friend, her bridge mate, the doctor's widow, said, "You go and do it." And over 2 years, I saw her in subsequent years, over a couple of years, tapered off prednisone, perfectly normal, everything fine, never had a stroke, never lost vision. So those are those are things you'd like to pick up. Love to do that. Crystal examination, crystal problems. Anyone in you or anyone in the family has had a history of gout or kidney stones. Kidney stones give us a tip-off sometimes of metabolic diseases, particularly things like handling calcium. And I had a lovely patient years ago, came from Spain, didn't speak any English at all. Her son, who's sort of an international business guy, brought her. Been treated for rheumatoid arthritis for at least 28, 29 years with methotrexate, still a good medicine. And ends up that she had an elevated calcium. She had hyperparathyroidism. The whole time she was being, treated, for rheumatoid and the calcium problems, the parathyroid disease, hyperparathyroidism, or gout can cause just as much destruction and deformative arthritis as rheumatoid. So you always want to know, are these metabolic things going on that you can make a difference with? And it was fascinating because we got her parathyroids taken out after all that time, and just made a tremendous difference. For a while there, her calcium, early my guest, had to keep after get calcium in there. Hungry bones hadn't had calcium in them for years and years. Other metabolic diseases in the family, things that go along with autoimmune diseases. Anyone else with B12 deficiency in the family tends to run in families. Diabetes, thyroid disorders in you or the family members. So often fun to pick up things, where the patient will say, I've got this, but that reminds me of my daughter who's had this problem. Can we get a look at her? And probably the person who knows the most about Sjogren's, other than Ida Powell, in Lynchburg, Kathy Hammett, and she had a daughter who was having some problems. Ended up she had autoimmune thyroid disease, so we filed that away and we said, okay, here's another autoimmune disease, expected in the family, where Sjogren's runs in the family. What else is happening? Well, years later, this girl was exercising and developed a thrombosis in her arm. That's very unusual for a young person. But knowing because she was in this autoimmune family, guess what? There's some conditions called antiphospholipid antibody syndromes where people can tend to have increased thrombosis and these things occurring in the blood vessels. Because we knew the family history, we got that diagnosed, early on, and probably saved her some additional problems that could have occurred with handling that. So now, let's see, that was probably 15 years ago. So guess what's happening in COVID with inflammation, with thrombosis? These people are having, because of the hyperinflammatory stuff, an increased tendency to thrombotic problems, blood clots, and those are things where they're losing the arms and legs and limbs, from unusual COVID reactions. I thought it's been most interesting, sort of every part of the rheumatology stuff, as I see the things presenting in COVID. And the thing we always try to control in rheumatology is inflammation. We know that inflammation is what causes bone destruction, joint destruction, and something that causes pain. We can often control that. If we do, it can often prevent a lot of disabling joint deformities and problems and disability. But we have to be aware of that and the way it runs in families. And now, of course, the exposure to ticks. So important, such a problem. So what are the infectious things that people may be exposed to, and what things relate to the family? The first patient that I had, I hope you're writing down because you're going to be graded on this. First patient I had with alpha-gal disease, came in, and she had presented just with a skin rash problem. But knowing the family history, the area that had tick exposure and so on, checked her problem, and she presented as an ANA. Does she have lupus? And she had no evidence of lupus. I'd ruled it out years before, but she presented with a giant hive. So now this infectious disease problem, we diagnosed her as having alpha-gal. What ended up, her mother was my patient. Matter of fact, from here at Westminster Canterbury. And knowing that, her mother had been followed with a chronic arthritis for years and years on methotrexate, steroids, Plaquenil, and so on, never defined as definite rheumatoid at all. but a chronic inflammatory arthritis. So I thought, well, that's strange. So I went back and then checked Mom, and guess what? Mom had alpha-gal as well. So this thing had turned from an infectious disease, more prominent as far as meat-related flaring up of joint symptoms or anaphylactic type reactions, to a chronic type arthritis. That's one of the things that worries us, today. The young people with COVID, we're saying, well, it's a milder disease in the young people. The Delta variant has shown us that's not so mild in younger people, 30s and now on into the kids and so on. And what's going to be like in 20 or 25 years, from now. I think that the infection that you get now may be starting some things that are going to have chronic sequelae. And the idea is, well, I don't have to worry about getting my vaccination because I'm younger, it's not going to be as bad. You may have regrets, years later. Following the epidemic, 1918 flu epidemic, following up a higher incidence of Parkinson's 25 or 30 years later interests a lot of us. So we don't know these sequelae. That's why I've always pushed the idea, I'd like to eliminate that acute disease, because I think we can manage things later on a bit better and avoid some problems. That'll be one of the real themes later on, and that is, how do we predict what's going to happen? How do we prevent it? And one of those is my friend vitamin D here. I still love that. And that'll be another thing we'll be talking about. Well, what about another infectious exposure? Have you been around friends that have been sick? How about in kids and children? And my daughter, who's teaches in elementary school down in Atlanta, and everybody that's got any daughter that's teaching will tell you the start of the school year, all the teachers get sick. The kids are bringing in their cold, they're sniffling and so on, and particularly the first graders, and then they're doing it in a mask as well. So, with these sort of things going on, and these infectious things, a common thing that occurred is the kids came in, and the individual father might say, well, yeah, 2 or 3 weeks ago, little Susie was sick. And Susie had a thing called Parvo Virus. It's one of the fifth disease, slap cheek appearance, red cheek, febrile illness in children. Like a lot of things with the children, got over quickly. 2 weeks later, Dad's seen in the emergency room where I saw him. And I remember because it was my 50th birthday. And he was there, and I walked in. He said, geez, I feel terrible. I feel like I'm 50 years old. And he's lying there, and his joints are swollen. He can't move. And I said, well, I'm 50, and I'm in a lot better shape than you are. He had Parvo virus. The Parvo virus in the adult presented mimicking lupus. It looked more like lupus than a lupus patient did. His skin rash, symmetrical polyarthritis, elevated sed rate, and chest pain and so on. He was really sick. A couple of days with some low-dose prednisone, it was much, much better. So what's happening then, and now we're seeing intriguing things with infections, people with long haulers disease, familiar with that with the COVID. Long haulers and was called by one of my former patients regarding her daughter-in-law. And her daughter-in-law, family had COVID, husband, son, and her. The other two got over it fine. 2 or 3 weeks later, she starts having the fatigue, horrible aches and pains everywhere, headache, loss of taste, sense of taste and smell. She has long haulers disease, and I'll tell you, it's very difficult finding things to do about that. It's a real problem. But interestingly enough, in rheumatology, they find that some of these people have elevations of things we call the cytokine system. This is a system of part of your inflammation, chemicals and elements that have to do with more and more inflammation in your system. And some of the arthritis medicines may be useful for long haulers disease. Well, it's interesting. These patients reminded us of people with chronic fatigue syndrome. These people reminded us of people with fibromyalgia. And I wonder back in the history of some of these people who have had this, particularly chronic fatigue syndrome, where was that thing that triggered this off? Was there, a viral infection years ago that we didn't know about that later on caused these problems? And I hope that's going to give us insight into better treatments for these people. Most of the time it's been sort of stuff like just live with it. Perineoplasty problems, we always have to worry as we get older about some underlying symptoms maybe relating to underlying tumors developing. And we had all sorts of things mimicked. I guess the hepatitis B, hepatitis C, everyone's more or less aware of, where they develop into a vasculitis, inflammation of the blood vessels diffusely. Needing specific treatment, the best thing is to try to avoid that through their vaccinations. May be feeling the same way about COVID later on. At this point in working up the patient, we'd say, okay, I've got an idea about your history. I've got a suspicion that maybe we're having symmetrical inflammatory polyarthritis. So where do we go from here? It'd be a matter of treatment and diagnosis. The rheumatologist is never at a loss for lab tests to do. I love lab tests. My number one most favorite lab test is the sedimentation rate. Cheap and very helpful, very sensitive, non-specific. And I want your sed rate, measure of inflammation, to be less than like 10 or 12. And when you're getting up to 30, 40, or 50, or 60, I know that if we treat you and we get that sed rate down, you're going to feel better, less joint pain, less stiffness, and so on. One of my office staff, her daughter her sister was in the hospital and was in with, it felt like vasculitis. She'd just broken out with funny splotches and red discolorations of her fingers and so on. And it ends up that was something we saw early on with patients with COVID. Some of these people are getting into the thrombotic problems in their fingers and joints. We're having this same appearance of antiphospholipid antibody syndrome. This girl's case, she got real cold. When she got cold, these joints and all got worse. The skin got worse and so on. So she had a thing called Cryoglobulin Anemia, very unusual. And as you may know, in the last few years, the emphasis in medicine has been how quickly can we get you out of the hospital, get you in and get you out as quickly as we can. And sometimes their goal is to say, we're going to get you back to your baseline. Well, your baseline may not have been all that good. But like to say, on the baseline, I'm on oxygen and can't walk 3 feet and so on. No, I'd like to do better than that. But these folks that say, well, what can we do to really make a difference? This particular individual, she was having the arthralgias and so on, and they went ahead and sent her home. They put her on a prednisone taper. She said she was feeling a little bit better, and I was not doing consults at that time, and it was almost out of practice. And the consult was scheduled, so I think she came in Friday real sick, and no one was going to be able to see her till Monday or Tuesday. And meanwhile, they discharged her. So that's bizarre. Got a copy of her lab test, and her lab test, she had a real high calcium level, just like you could have had with hyperparathyroidism. Well, that's unusual. Did she have anything else to go along with it? Well, she was anemic, and here she was sick and inflamed. And I called over and got the rest of her lab test, and the total protein to albumin ratio, these different proteins and so on, just very abnormal. So I sent over to the lab, and we had one of these wonderful old lab test folks at Baptist at that time. And she called. She said, Dr. Wilson, this protein electrophoresis really looks abnormal. Something's wrong. And so I called immediately, and she had been discharged, got her seen by Dwight Oldham, readmitted, and she had myeloma presenting. She was on her way to kidney failure as well as all these other sort of problems. So we always worry about some underlying systemic disease that's presenting with aches and pains in the joints. So I guess I can't give you a feeling of saying, oh, it's nothing, it's just a little arthritis, because in rheumatology, it wasn't the case. We always look at it and say, what is the clue? What's going on? What's this telling me about? And I'm not an Eeyore looking at always the bad thing, but I always want to sort of consider all these possibilities. So who in their workup now has figured out what they've got? Who thinks they got an inflammatory arthritis going on from what we've said? Morning stiffness, additive arthritis. So you tell them most of y'all have wear and tear? Age-related arthritis? Oh, no. Yes?
I haven't heard you say anything about
Hashimoto's is dear to my heart. And that's because at the VA hospital, when I was an intern, in order to get special tests done, you had to have a special pink sheet form filled out, good for any kind of VA or military thing. And I had a wonderful office secretary, and they had not done the test. I wondered, and when I got the form, I realized why. And because she filled it out, has Hashimoto's disease instead of Hashimoto's. And Hashimoto's is the most common cause, I think, Earl can correct me or not, of probably subsequent development of hypothyroidism. And it's an autoimmune disease. It's much more common, in patients that have some of these other disorders as well, Linda. Did you have any other thoughts, any association with that? It can be in lots of folks, yeah. And, okay. And the most fascinating thing that's been going on recently, I get calls or different things, folks that come up that are kind of intriguing. And to my best friends in Eastern North Carolina called, and they're worried about their son-in-law. Son-in-law was having spells. And the spells was he would just sort of fall out during the day and couldn't relate it to anything. And he's young, about 38, 39, young, maybe even 40, still young. But he quite appropriately had a workup, cardiovascular workup, monitored. Was he having arrhythmias, falling out because of arrhythmias or heart block? That was normal. And what about a neurology evaluation? The neurologist felt like he had maybe slight abnormalities, maybe a low-grade seizure type activity. Put him on some seizure medicine, and they called me and worried about him. Well, there's only one thing I knew about Cliff. Cliff's a hunter. I said, okay, I want you to take him to his primary doc and tell him we want to go ahead and do an alpha-gal test. And as happened so many times with patients I've asked to go to the primary doctor, I can't tell you on a handful the number of times that the primary doctor went ahead without, I was going to say bitching, I'm about griping about doing that test, did not want to do it. Oh, he doesn't have alpha-gal. Just tell him just to do the test, humorous. And I said, matter of fact, I found out that Cliff's sister had Hashimoto's, had autoimmune thyroid disease, and guess what? She had alpha-gal. Happened to do an ANA as well. That's a waste of money and so on. Both tests were positive. It ends up that his symptoms falling out were like a very early presentation of going into anaphylactic shock. And instead of having a very frank, severe anaphylaxis where he had to go to the hospital, his was just milder. But we probably have many, many cases of those that are not being diagnosed because these spells are not typical for a meat allergy. Anyway, that sort of taking care of his presentation. So what else? Let's say that, yeah.
Immediate reaction, or is it long-term if something like that's going to happen?
There I think it was an article just in this past week, either JAMA, I think it was probably in JAMA, talking about that, and some of the folks, had the problem, within a short time following vaccinations. So I don't think it's predictable. I think we're going to find that there's a subset of the COVID patients that are more prone to this, and maybe some of them are more prone to it early on when the disease is inflammatory, others later on after the vaccination. And one of my church members called, and he had been recently diagnosed with alpha-gal, and had a problem with that presented as diarrhea. Then I had COVID, went through his family, got the vaccination, and he has been in horrible shape ever since. Can't predict. But earlier on, they said that the COVID patients that they found by genome checking their genome-wide association studies, this group that had A blood type A blood, ABO blood group, and they had a certain set of loci in one part of the genome, that if you had those two things together, you were much more likely to have the bad sequelae that would end up with having to be on a respirator, maybe having the hyperinflammatory response, and needing Decadron early to prevent the blood clots. So I think it's very unpredictable. I guess, if someone starts off early on with COVID, I would probably be doing this baby asthma or something like we do with antiphospholipid before they've had that problem. So it seems like a scary bunch of diseases out there, but you're trying to get a hold of them earlier. And then seeing these interesting associations with things that are coming along, like the COVID, I think are very fascinating. Okay, somebody out there is having morning stiffness, symmetrical involvement of the joints, not so much the DIP joints, and they're going to say, what lab tests are we going to do? Well, we're going to take a look at what we call acute phase reactants. Acute phase reactants are the sedimentation rate and the C-reactive protein. Those two things tell us about active inflammation that's going on. And occasionally, patients for some reason with psoriatic arthritis will often have a normal sed rate, but their C-reactive protein will be more active. So that's interesting. You know what the C-reactive protein is looked at mainly? It's in cardiology. The cardiologist looked at your C-reactive protein. And that's because, underlying probably the nidus for a lot of the atherosclerosis that develops is inflammation in the blood vessels and coronary arteries. And I think that probably is one of the things that relates the increased problem with cardiovascular diseases is the cause of more deaths in people later on who've had lupus or rheumatoid. They'll tend to have more of the atherosclerotic cardiovascular disease. So can we prevent that? Okay, so you have a symmetrical polyarthritis. We're going to take a look at the acute phase reactants. We're going to look at the rheumatoid factor. I'm going to tell you when we talk about rheumatoid arthritis about 5 or 6 other things that cause a positive rheumatoid factor other than rheumatoid arthritis. Not a very specific test. Then there's a wonderful term called immunosenescence. Well, immunosenescence, you mean old age immune system? Yeah. And guess what? If we all lived long enough, people say we'd all have positive ANAs, positive rheumatoid factors. And I think some of that's true because we continue to have different things that hit us and trigger off these diseases or hit our immune system and cause our immune system to react. It's one of those things not good to fool Mother Nature too much. The immune system gets angry, then it has these autoimmune reactions. And autoimmune things, I guess the earliest term of that was by Dr. Ehrlich about 1915. And his autoimmune diseases he called horror autotoxicus. What a great name. Autotoxicus, your body's reacting against itself. That is horrible, particularly at those times. I want to avoid that. So we're going to get the rheumatoid factor. We're going to get an antibody to CCP, much more specific test for rheumatoid arthritis. And what are we going to do to treat you initially? You're on an early onset of rheumatoid arthritis. I'm going to check your vitamin D, and it's going to be low. So we're going to be doing it with vitamin D. Maybe early on we're going to be treating you with Plaquenil because no one knows exactly how Plaquenil works. But it seems that with the vitamin D sometimes is enough to get this inflammatory condition under control. 6 or 8 weeks later, if it's not, we may be going adding methotrexate. And sometimes that's all you need. Get people into remission, you're able to taper off. So everybody's sort of individual at that point. Well, if it's a spondyloarthropathy or if it's inflammatory bowel disease, we know that getting the inflammatory bowel disease under control will help the arthritis. But otherwise, they end up needing some of these biologic agents. Biologic agents are very interesting because now it looks like people with rheumatoid on these biologic agents, instead of having problems with COVID, may have been protected in some of the COVID problems. So COVID's opened up a whole new world of concern about inflammation. But as far as your rheumatoid, we'd start there. What about your problem was you say, gosh, I really want my joints, but I'm weak in my muscles, particularly working overhead, lifting my quadriceps, my biceps, and we're going to be looking at your CK. We're looking at your thyroid because that low thyroid is a common cause of muscle type problems. So it just opens up lots of things to look at. And I'm just going to open up for further questions now and share the confusion. Carol.
Do you know of a natural substance to replace Celebrex for rheumatoid arthritis?
I know that turmeric has been used, and we're going to talk about supplemental and alternative therapies, herbs, and so on a little bit within the rheumatoid talk. But and we have a handout, and handouts, if you can't make the next talks, will be available. But turmeric has been one, not particularly that much better. I went into mourning when they took Vioxx off the market, and I had many patients who were doing so well with Vioxx, they weren't having heart problems, and as advertised. I've been on Celebrex for 100 years, and so it's much easier on the stomach.
I can't take anti-inflammatory medicines, and I have osteoarthritis, at least, and multiple problems. So when I do have osteoarthritic pain, what can I do for that? I mean, other than ice or whatever.
And then the NSAID can't be
Yeah,
used.
I can't take that because I get those nosebleeds. I have
Also, Rondu.
I have HHT and Raynaud's.
Okay, hereditary
Scleroderma.
hemorrhagic telangiectasia, and yeah, they don't want that. So the Tylenol, some of the rubs that you can put on these joints, individual joints, like on the knee or something like that, that's bothering you, Voltaren rubs, diclofenac, didn't seem to help. The other people thought also that you still got, if it's an NSAID that's topical, we may still have systemic effects. So I'm not sure that's the safest thing. So you're back to Tylenol, acetaminophen, and if it was real bad, you'd say, well, okay, well, opioids, and obviously we're trying to avoid that nowadays. That's again, the pendulum always swings too far one way or the other. And I would have many patients who have such severe problems. They're not surgical candidates, have terrible spinal stenosis, horrible pain, and they really need to be on chronic pain medicines of some sort. And the other things just don't do it like opioids did. Yet they have to go up like once a week in person, to get their prescriptions. And the pain people help with that a whole lot. Yes.
And she calls my osteoarthritis erosive, and I can't find anything about it. Can you explain that?
Yeah, erosive arthritis, if you take a look at pictures, you can start to see little erosions in the bone. And it seems like osteoarthritis will often go through a spell several years, which is more active in general. And some people have gone ahead and treated that like inflammatory rheumatoid, sort of an inflammatory osteo. It's more than simple osteo. And as we talked the other day, how have you done with what you're on? Yeah. We got going with methotrexate, and the biologic agents were so popular. I really wasn't using the biologic agents that much because with the methotrexate, Plaquenil, we're able to often control things without the biologic agents and vitamin D.
How much vitamin D? I take it, but I don't know.
With the COVID thing, I was urging people to get anywhere from 2,000 to 5,000, a day. And as I had all my kids on, my grandkids and so on. Kid? Yeah, you have to look at how many international units and so on. Oh yeah, D2. Oh, I'm sorry. D2 is prescription, and D2 is from lanolin. D2 you may have a reaction to if you have alpha-gal, and if you get the gel form of D3, you may have a reaction with alpha-gal G3. Some people do, some people don't. Most people don't, but either of those forms seem to be okay.
So if you have an allergy to wool, you would not want to take the D2 because lanolin comes from.
I haven't seen that problem as far as like a topical allergy. That's interesting. Try it. Let me know how that happens. I don't know. It's interesting.
I was thinking that before we leave, that you should be sure to tell people about Ovacalp.
Ovacalp is without a doubt the world's greatest medicine of all time. And it was developed, and the two young guys in the Navy, if they'd been smart enough, they would have gone ahead and gotten a patent on this stuff. In the Navy, I did active duty sick call Diane, you'll tell read this, I know. Okay, and with my friend Mike Burton, he had done a general rotating internship at University of Kentucky. Kentucky blue and blue, hated Duke, hated Christian Laettner. We still got along, and we had in the morning came in one time, and Mike, our sailors, you never had a healthy sailor on Monday or a sick sailor on Friday afternoon. So Friday we'll just keep you, watch you, dispense you over the weekend. No, we're not going to do that. Mike called in and said, come here and look at this. This fellow, got up this morning, Monday morning, and he's paralyzed. His leg is paralyzed, and he had to lay him down on this table. I said, oh, interesting. And he said, yeah. He said, okay, Jones, now get up, stand up. So he stood up, obviously not paralyzed. And I said, what in the world? He said, well, I put him on Obacalp. We had been doing sick call on the Grand Canyon tender ship, and we had a fellow who had a terrible migraine. We thought migraine headaches, terrible headache, tension headaches, good sailor. And he came in one day, and it's the usual thing. I'll give you some Demerol. Take a tablet, you'll be fine tomorrow. Come in the next day, still having problems, give you a shot of Demerol. That's going to take care of it. Came in the third day, Dr. Burton and Dr. Wilson, this isn't taking care of things. We said, well, okay. And Mike Burton, my friend from Kentucky, turned to me and said, the only thing that's going to help this is Obacalp. I said, Obacalp? I said, I just finished training at Duke. I said, a pretty good place, never heard of that. He said, I'll show you. And he took a syringe with saline and said, Jones, we're going to give you this shot of Obacalp. And before it gets out, you're going to fall asleep for 20 minutes. The headache's going to go away. When you wake up, you'll be fine, no side effects. Well, he didn't even get that needle out of the guy's, deltoid, and the fellow was asleep and snoring. 20 minutes later, he got up, feeling fine. And I thought, well, Obacalp. Well, that started the Navy use of Obacalp Odic, Obacalp Orthopedic, Obacalp Ophthalmic, and it always worked. And it's placebo spelled backwards. And patients would call you and they say, that medicine you gave me, I'm seeing stars. I don't think I can work tomorrow. Does it cause that? Nope. I think I'm having all kinds of belly pain. I don't think I can work tomorrow. Does that cause that? Nope. No side effects. What a great medicine. And at the end of the first year, the Navy decided it's best to separate Dr. Burton and myself. Another story. And so he was gone, and I was doing dependent sick call. And one of the chiefs did not like us using Obacalp. And one time he came down to sick call and said, Dr. Wilson, Dr. Burton, we are out of Obacalp. So I said, well, how in the world can we be out of nothing, Chief? Just give them the pink pills. They worked as well. We had used B6, vitamin pills because they tasted terrible, so it must have been real medicines. Kept them locked up, as a prescription medicine. Anyway, thought nothing more about it. And one day, Jones' ship was getting ready to go out to sea, and I got an urgent call saying I was fishing sick call on another ship. Burton was off at sea somewhere. They said, Jones is calling, and he's got to see an emergency. And I thought, well, this is where Jones is going to show he's really not a real sailor. He's going to try to get out going to sea. Well, he didn't. He said, I did what y'all said. I've tapered down my Obacalp down to one a day. I'm doing fine, but I ran out of Obacalp. And this stuff is starting again. I just need a new prescription. And it did fine, went out. Best medicine. So it's still the best medicine. Unfortunately, nowadays, we have nocebo, more effects, and because we're so worried about stuff, when you listen to any medicine on the TV, would you take that after they go through all this stuff and say, good Lord, it'd be better if I just go ahead and die than take that medicine cause this, and this. Obacalp, wonderful. Carol, maybe we'll get some of the Obacalp salve, work on that. Mary?
For those of us who are lucky enough just to have old age stiffness when we get out of bed in the morning or when we've been in the car for a while, can you explain physiologically why it goes away when you start moving around and what's happening? Why is the stiffness there and how does it go away so quickly?
You need Obacalp. Mary, I don't know, but you think about a couple of things, when it occurs when you're at sleep or rest or so on, thinking about some of the changes in the synovial fluid that's there in the joints and around the bones, and knowing that, why does gout often attack in the middle of the night like that? It's in the fluid and so on, but at night, you maybe get a little more, dehydrated, it gets a little more concentrated, the temperature changes, the crystallization is different. So there must some sort of changes there. And part of the treatment with osteoarthritis, things like that, were Synvisc, injections of hyaluronic synthetic hyaluronic acid type things. Maybe there's changes there that once you get moving and get them moving a little bit, it kind of pumps out some of that and helps with it. Just thank goodness it does. Boy, it sure changes from one another. How about after, how many of you, know that when you're on a trip, every 45 minutes you're going to stop the car, right, get out, exercise, twist and turn and so on so that, you won't be stiff. Anybody do that? Something about the flow, circulation, the flow in the joint itself. Good question, and I don't know. I can just speculate, but true observation. Any other questions?
But the autoimmune problems like juvenile type 1 diabetes and I'm not going to pronounce this right, Hashimoto's, Parkinson's, why is it that there's so many in one family and one side of the family? This ulcerative colitis, just a collection of autoimmune problems that, like my family's cute and adorable and lovable, and I wouldn't have traded them, but why so many autoimmune problems?
Well, I think, and we'll talk about that again, about what's the autoimmune stuff is your inherited susceptibility, and again, attention to what triggers it off, in different folks. But and we'll talk particularly about that in several different examples of the susceptibility. I think an interesting thing is the susceptibility that we've got for some of these diseases, like the autoimmune inflammatory bowel disease and so on, much less than the susceptibility we all have for alpha-gal. We're 100% susceptible to that. None of us have, the alpha-gal. And so why is it getting more and more frequent? And that's partly related to a combination of things: direct problems, increasing availability of the ticks are moving up because of global warming, and the good old deer. So it's a combination of factors.
I read some articles that recommended if you have these autoimmune diseases not to get the vaccine. What do you think about that?
Well, I think that in some people it may aggravate things, but I think I think you just have to look at risk and reward. I would just take the risk. I just don't know the numbers. I'll try to see if I can find something on that. To me, the potential reward is worth that risk. Now, I have nothing scheduled until Parkinson's dance, which was called off. So I have nothing till supper time. So if anybody says I want you to take a look at the form here, I'll grade your test and we'll tell you what we need to do. Glad to do it. Yes.
Dr. Wilson, I know that I've had some people ask me, knowing that you were going to do this program, who is the rheumatologist they should be calling now?
That's a great question. I heard that Dr. Kenny is retiring. Earl, you heard that? Don't you love that? I love those ads on TV. Oh, just call your rheumatologist. Easy. Yeah, there's not a lot of them. That's a problem. I certainly don't mind. It's so interesting. Sometimes on the individual patient, we can find some things that are helpful. Okay, well, very good. Yes.
I'm new to this area, and I really do not have a rheumatologist yet.
Are there very few rheumatologists in this area?
It's only one.
Only one?
Yeah, Dr. Kenny over at Ortho, Virginia, is a rheumatologist. There's some at A few are now, Carillion, I think, it's decreased, and otherwise UVA and Martha Jefferson area. Did you have a rheumatologist?
Yes, I did have. I just moved here in May.
From where? Where'd you move from? Could he maybe look up in the directory and maybe try to make a plea recommendation to the rheumatologist, say, I've got so-and-so, could you please see her? He'll have a directory for the rheumatologist around. We're going to talk about Plaquenil, Sue, in the future. Because the idea, again, can we predict these things? We're going to see more autoimmune diseases. Can we prevent them?